Great. Good evening, everyone. I'm Amol Tambe. I'm hosting the BESS T-Journal Club meeting today. We've got just a couple slides that I'm going to run through, just to go through the housekeeping rules. We have this session which is going to run for maybe an hour and a half. Plan is to finish by 8. This session is going to be recorded. The audience will be muted. You can post your questions, and these will be facilitated at the end of each paper or at the end of the session. There is going to be some polling, so please participate. These questions will come up on your screen. And as I said, we plan to finish by 8. Today we have the Cambridge team, and the topic of the Journal Club today is elbow trauma. We will start with Lee, who is going to present a couple cases, which will then be followed by Mr. Nair, Sandeep Nair, who is going to discuss the heterotopic ossification paper. The paper should have come through already. We will then follow with the next paper, which is the posterior approaches. This is the Stanley paper. This will be introduced by Mr. T.J. Melton. Thomas is a shoulder and elbow clinical fellow currently in Cambridge. He has come to Cambridge after finishing his orthopedic residency in the Washington State Madigan Army Medical Center, and he plans to return back to practice when he finishes his fellowship. We also have Sama Chowdhury, who is a consultant shoulder and elbow surgeon. We have 3 eminent panelists. There is Lee, who will be facilitating some of the questions. We have Graham Tidderly Strong. And has Neil Kang joined, Lee? I don't see him.
Yes, he has.
He has. Excellent. So thank you very much, Cambridge team. The dais is yours.
Great. Thank you. One technical paper, a randomized controlled trial, and then a few approaches papers because I like approaches. So this is a 24-year-old who falls from running, sustains a simple posterolateral dislocation, no injury. There's the red graph said one when you see them in clinic. We're quite used to thinking about DVT prophylaxis, but do we give HO prophylaxis to every patient who sustains a complex elbow injury? Who do you give DVT prophylaxis to? So here we have a simple dislocation. Do you give them indomethacin? Do you offer them radiotherapy? Do you offer them a bisphosphonate? Do you do something else? So no one yet is giving HO prophylaxis in someone who sustains a significant injury to their elbow, which is fair enough. I don't think anyone should. There's their radiographs at 6 weeks. There was no other medical history, nothing else significant in this person's life. But now we see that ball of callus forming there in the front. Who now thinks it's time to offer them a little bit of heterotopic ossification prophylaxis? There should be another vote. Okay, so fair spread. A lot of people just say carry on. A few people are thinking to change now to indomethacin. One offering radiotherapy and one offering other. If you have the access to the chat function, you can put in the chat function a comment. If you have the other sort of option, perhaps you could just put in there and maybe we can talk a little bit about that, the other option for the heterotopic. So there we are at 6 weeks. There we are now at 6 months with a pretty established HO. I'm going to pass on now to Sandeep to talk about in the medicine paper from Canada.
Great,
You can
thank you.
share, Sandeep.
Yeah, let me share my screen. Can you see that?
All perfect, sir.
Brilliant. So thank you for this opportunity to present. I'll be talking about this paper, indomethacin for heterotopic ossification prophylaxis following surgical treatment of elbow trauma, a randomized controlled trial. And this came from the group in London, Ontario, published in the Journal of Shoulder and Elbow Surgery last year. So to give you a bit of a background, heterotopic ossification, or HO, is a recognized sequelae of elbow trauma, reported in up to 37% of cases. Non-steroidals have been thought to help reduce the incidence of HO. They are thought to do this by inhibiting cyclooxygenase 1 and 2, which inhibits osteogenic differentiation of osteoblastic progenitor cells. And this is something which has been very extensively looked into in the world of hip arthroplasty as well as pelvic trauma. And a Cochrane review of 16 RCTs in hip arthroplasty showed that NSAIDs reduced HO by 59%. But the literature has been a bit more limited in the world of elbow, and there's been no RCTs up until now. So here's George Atwell, the senior author of the paper, thinking about his research question for this study of indomethacin and NSAID following surgically treated elbow trauma, more effective than placebo at decreasing incidence of HO. They carried out a single center, randomized, double-blinded, placebo-controlled trial. So it doesn't get much better than that. The population that they looked at were between the age of 16 and 85 with elbow trauma awaiting surgery. They looked at open and closed injuries and a whole host of different types of elbow injuries. And they excluded people with head injuries, burns, spinal cord injuries, which are independent risk factors for HO, as well as any contraindications to taking NSAIDs. The intervention was indomethacin, given for 3 weeks with PPI cover with pantoprazole, and their comparator were placebo equivalents for both of these. Their primary outcome measure was the appearance of HO at up to 1 year post-op on X-rays. They also looked at the presence of non-union, defined as pain and motion at the fracture at up to 3 months post-op. And they looked at a whole range of patient-reported outcome measures, as well as adverse events. And the follow-up was up to 1 year for the radiographic outcomes and 2 years for their clinical outcomes. And they classified HO according to the Bruker classification system. Their stats, their study was done as an intention to treat analysis, and their power calculation showed that they needed a minimum of 160 patients. And this is the Bruker classification they used. So grades 1 and 2 on the left, which is the more minor HO, and then grades 3 and 4 on the right, which they've defined as a severe HO. Overall, they screened 265 patients over a 5-year period, of which 158 were included in the study, and their mean time from injury to surgery was 7.6 days. And this is our table showing the spread of injuries, predominantly elbow fracture dislocations, as well as some distal humerus fractures, olecranon fractures, and some other things in there. From the indomethacin group, 8 patients, or 10%, had GI side effects and actually stopped taking it 2 weeks before the prescribed 3-week period. When you look at their primary outcome, the incidence of HO was 49% in the indomethacin group, of which 25% were severe, these Bruker grades 3 and 4, versus 55% in the control group, of which 27% were severe. So there was no statistically significant difference in HO, severe or any form, between the two groups, and they had no non-unions in either group from any of their patients. In terms of their clinical outcomes, again, there was absolutely no difference in any of the PROMs or range of motion scores at any time point, and they had the exact same percentage of complications in both groups, and these were the complications that they found from their summary table. So what's the conclusion here? Well, it's that indomethacin doesn't prevent heterotopic ossification in operatively treated elbow trauma. And in fact, it may even cause some GI upset even when covering with a PPI such as pantoprazole. So what are my thoughts on this study? Well, there's a lot of good things about it. It's a double-blinded placebo-controlled RCT, which is the highest in your evidence pyramid. They had very clear outcomes. They looked at multiple validated PROM scores, and they had a good follow-up period. They had very robust stats and carried out power calculation in order to minimize error. And they minimized bias by it being a placebo-controlled double-blinded design. What was not so good about the study? Well, it was a single center, so it may not present the broader population or different healthcare settings. There was a lot of heterogeneity in the patient groups they looked at, so this may differ depending on age of the patient, their other comorbidities, the exact injury, the approach you used to fix it, how you fixed it, and you need a much bigger study population in order to carry out subgroup analysis for all of these factors. And another thing is that they didn't actually check compliance with the medications in their group. And then what's the ugly? Well, it's that we still don't seem to have a good pharmacological way to minimize the risk of this pretty devastating complication from elbow trauma. So where do we go from here? Thank you very much.
Thanks, Sandeep. Great presentation. Are there any questions either from the audience, if you put it in the chat, if there's any comments from the panelists on the paper and the presentation? Neil.
Lovely presentation, Sandeep. I like the way you put it into the good, the bad, and the ugly. One of the things that I couldn't work out from the paper was, did they all have the same? You pointed out that they were a heterogeneous group of different types of injuries. What about their post-op rehabilitation? Was there any mention of that?
They don't talk about their post-op rehabilitation. So they did whatever they would normally do for these injuries, but in their methodology, they haven't specified how they're fixing these things and what their post-operative protocol is. They don't specify that it was a standardized post-op protocol. So we have to assume it isn't.
Thank you. And if we've got another time for one more, is what about, did they actually substratify any of the results, especially the ones that you said there's a 10% dropout, was it of the indomethacin?
So they did an intention to treat analysis. So these people who stopped taking indomethacin also continued in that group. They don't provide any additional stats as an ads treated analysis. We don't know how that would differ, and they don't provide any subgroup analysis. They stuck to what the study was powered for, and just provided this intention to treat analysis. But it's a pragmatic trial, so you're assuming that in real life, probably that percentage of people will also stop taking it.
Sandeep,
I
I
was
have a
wondering
question.
if there was a correlation in terms of the injury types and the HO.
Yeah, they don't.
which
They
they have
don't give that breakdown.
Sandeep, I have a question.
Yeah.
Hello.
Hello.
Yeah, I just quickly wanted to ask you, very nice presentation. Thanks for going through that paper. The final follow-up, they said, was it 2 years in the paper?
2 years for their PROM scores, yeah.
Yeah, I suppose this is for the panel, is to say HO would be well established between, say, 6 months to a year. And if the paper was looking at effectiveness of indomethacin in reducing the incidence of HO, I wonder why they went down to the 2-year kind of follow-up, when already by 1 year, it would be very clear whether they have addressed the problem of HO with indomethacin or not. And whether they've made any comment about this in their discussion or not.
So their primary outcome measure was the presence of HO at 1 year. So that was their primary measure. And actually, they don't comment on radiographic outcomes beyond 1 year. They've continued collecting their clinical data for 2 years. Which has made no difference to their outcomes. So whether this has any impact, I have no idea.
Sure, thank you.
Thanks. So although this wasn't an operatively treated case, maybe the time will come when we find something pharmacologically that we can offer patients like we do for PE or DVT prophylaxis. Sandeep, if your elbow, you've just dislocated it, are you going to take some indomethacin to prevent your HO?
No, definitely not. I think it's strong enough evidence to say not.
And are you thinking you would take something else?
Well, and the question is, what else is there? There's been one RCT looking at radiotherapy, which showed a higher non-union rate. So I wouldn't take that. And then so no, I would just get my elbow moving.
Okay. Yeah, that's I suspect that's a little bit of me poisoning you there, and I'm sorry for that. But yeah, I strongly believe that the prevention of HO is early active movement. But it's good to see that at the moment we don't need to poison people's stomachs with indomethacin. Would you agree?
Absolutely.
Okay. Any other comments from the panelists? So now we're where we are. So this was for prophylaxis of heterotopic ossification. But now we have established HO. We've got a big ball of bone that's formed, and we're now at 6 months, and we're coming to excise the heterotopic ossification. There should be another poll. What heterotopic ossification is, and sometimes once you see the lights in the horizon, you can't stop. I don't think you can add any prophylaxis once you start to see the little ball. There were a few people who changed and started offering HO prophylaxis at 6 weeks. I'm not convinced that it then really makes a big difference once the bone has started to form. You might as well just wait for it to mature. Do any of the panelists have any thoughts on that? Okay. So now we're going to excise HO. This is a totally different question. We now know that they bone form, and we're going to excise HO. Post-operatively, what do you offer them? Stop sharing. Question 3. Question 3. So, scenario now. You can write it. What do you offer them? Results. Anything. Salma, can you see the outcome of the poll? Yeah.
Yeah, 24% said that they would still prescribe indomethacin for HO.
So this is now if you're excising HO, so this would be a different selection. They've already showed you that they're going to form bone. Yeah, I don't think anyone's done the randomized control trial on that yet. Well, see. So he had 8 weeks in, and for me, got standard non-steroidal anti-inflammatory for pain relief and early movement. And there's the radiographs at 6 weeks, and there was nothing there at a year. This brings us on a little bit further to how are you going to get to this HO? I was lucky when I started back in 2005. I only knew 3 approaches to the elbow: the Kocher, the Kaplan, and the Olecranon osteotomy. So in 2000 elbow, it was easy to become an elbow surgeon. And I'd been taught those approaches by a shoulder surgeon. So let's have the next poll. You see where that HO is. How are you getting that HO out? Are you coming from the lateral side? Are you coming from the anterior approach? Are you coming medial? Are you going posterior? And so about 50% are doing a direct anterior approach to the elbow. Yeah, sometimes I think if there's lots of badness there, you might as well go right for the badness rather than escaping. When I first started, I think I would have gone lateral. But over time, I've become more comfortable with the medial approaches. And so I would have done I did an extended medial elbow approach, the EMEA, into an anterior paratricipital, medial paratricipital approach, the so-called Shanghai. And what I love about elbows and approaches is every few years we read another way to get to the elbow. And the next two papers I'd like to have presented are contrasting how much we can see of the elbow with the different approaches. And so the first case will be presented by Thomas Melton, TJ from America. But this is the case I want you to think about. This articular fracture of the distal humerus. Complete coronal shear, capitellum, trochlea, lateral epicondyle is off, subluxation of the elbow. How are you going to get to this elbow? Okay, perhaps you could share your screen and
Will do.
because when I started, all I would have had was the olecranon and osteotomy.
All right, can everyone see that? All right.
Yeah, coming through nicely.
Yes, my name's TJ Melton. Thanks for the opportunity to present as well. I'm the shoulder fellow here at Cambridge. And one moment, we got a little audio issue here. All right. Yeah, so sorry, I'm TJ Melton, the shoulder and elbow here at Cambridge, and I'm going to be presenting the first approach article. So this was the posterior surgical approaches to the elbow, a comparative study from Wilkinson and Stanley out of Sheffield, United Kingdom. It was published in the Journal of Shoulder and Elbow Surgeons in 2001. So this paper is relatively short and sweet, but the aim was to determine which approach between the triceps split or Van Gorder, the medial triceps reflecting, or the McCausland or olecranon osteotomy provided the greatest exposure of the distal humeral articular surface. And in terms of their methods, this was an anatomic cadaver study. So they had 12 adult cadaver elbows assigned to one of the 3 surgical approaches. Each approach was performed on 4 elbows total. After the completion of each exposure, the elbow was flexed to its limit, and the visible articular surface of the humerus was painted with methylene blue. The elbow was then disarticulated, all soft tissue attachments removed, and the amount of articular surface made visible by the exposure was expressed as a percentage of the entire distal humeral articular surface. And this is the image from the paper showing the 3 approaches. And A is the what they call triceps split or Van Gorder, which I kind of think of maybe as that triceps fascial tongue elevation approach. Approach B was the Bryan and Morey medial triceps reflecting, and they also take a tip of the olecranon for this approach as well. And then C is that classic McCausland or olecranon osteotomy. And in terms of their results, the median percentage of the visible distal humeral articular surface for the Van Gorder triceps split was 35%. The triceps reflecting was 46%, and the olecranon osteotomy 57%. So the olecranon osteotomy provided a greater percentage visible articular surface than the triceps split, although it wasn't significantly greater than the triceps reflecting approach. They mentioned that visualization of the capitellar surface was also best with the osteotomy and limited with the other 2 approaches, but none of the approaches provided good access to the radial head, and they were all limited in terms of exposure to the anterior articular surface of the trochlea. And here's again, another picture from the paper showing the methylene blue dye for each of the approaches, A being the Van Gorder, B the triceps reflecting, and then the olecranon osteotomy. And as you can see, the anterior aspect of the trochlea, even with the osteotomy in this paper, was fairly limited in terms of visualization. So in terms of the discussion, so in this paper, the olecranon osteotomy provided the greatest exposure, surface area of the articular surface of the distal humerus, although it still left more than 40% unvisualized, particularly anteriorly at the trochlea. The authors, based on this paper, recommended olecranon osteotomy for complex intra-articular distal humerus fractures. And that was the conclusion they had, I guess, in terms of additional thoughts and conclusions. As Mr. Van Rensburg mentioned, contemporary study could potentially evaluate, like the one we're going to review here shortly, additional exposures. One we use here being the lateral paraolecranon approach, or the elbow dislocation approach that, again, we're going to speak about momentarily. So been additional exposures sort of that have come up with over the past decade or two. And then again, regardless of the approach, something we talked about the other day in an approaches course, regardless of which approach could be used, if there was potentially you could get better exposure even with these approaches with manipulation of the elbow or form and space and different kind of positioning techniques and other kind of releases potentially. And that's all I have.
Great, thank you. If you could share the one slide back where they've just painted with methylene blue. Do you notice anything interesting about that? In terms of the dark part is what they can see.
Yeah, I mean, there's a lot that you can't, I suppose, on all of them, but even the osteotomy, it's fairly limited.
Yeah, so I look at this and I think all the olecranon osteotomy does is take away what's over the trochlea. Why could they not see what was under the capitellum? Because the capitellum isn't covered by anything. This is one of the first papers for me, and the problem with the way we used to do the olecranon osteotomies is we didn't used to do the ancillary releases around the elbow, traveling down the sides, down into Boyd's interval down the side, which would give you all of the capitellum as the sort of visualization options. But this is what I started in 2004, 2005. That's all I had. I couldn't see any of the part of this fracture of this case that I've showed you. If you were then going to be doing a olecranon osteotomy, a Van Gorder, or a Brown-Murray reflection, you really didn't get to see too much of the front of the elbow. Has anyone got any questions from the audience? Any panelists got any comments on that paper? And so let me just share my screen.
Stop.
So there should be another call on the screen. You are now in 2002. That paper has just come out. Question number 5. Sorry, I need to just relaunch the poll. You're in 2002. What are your options? What are you going to do? And so we've got still 46% doing the Lequenon osteotomy, because that's, what we've done. That's what Sean O'Driscoll taught the world how to sing, that we had to fix the distal humeruses through an Lequenon osteotomy. Some people do it, and that was the other option. That's what I knew. I knew a Kaplan and I knew a Kocher, and then I knew a Lequenon osteotomy. Genuinely, that's all I knew about the approaches to the elbow back in 2005 when I first started. Since then, a whole host of other approaches have become available to us. Recently published from Beijing, I think. Selma, is that right?
Yeah.
You present your paper from Beijing.
Great. Can you see that? Excellent.
All fine.
So I think we can all agree that the elbow is complex. That's what makes it interesting, but particularly when you start, it's quite intimidating and it's often very difficult to view. And when you're faced with something like this, I think often most people's reaction is, ouch, I'm unsure, help. And when you look to anatomy, often it's much more confusing because there are so many approaches, and even today's poll showed that people would approach things quite differently. And we know what beautiful surgery looks like, but the question is, how can we view things? And often our views mean that we have limited 2D views. And ideally, what people, especially when you're starting out, are looking for is something that really simplifies elbow surgery and ultimately gives you the best view. And what is the easiest way with the best view to achieve this? Typically, I think a lot of people with something like this might use the extended lateral approach, but it is quite difficult to get and view the posterior medial olecranon. And so this Liu group came out with a study, which is a new elbow dislocation approach. And what they've done is they've taken a paper previously published by Hoyt that describes a elbow dislocation approach, but they've then gone on to compare it to an olecranon osteotomy. So what they've described is you remove or you lift off the lucal and the extensor origin, and then you do a lateral epicondyle osteotomy, and the key bit is you try and stay about 4 centimeters away from the joint. And typically you can see quite a distracted view, but the addition that they've added on top of what Hoyt suggested was that with flexion and inversion, you can see a really beautiful view and a lot more. And they then compared it, so similar to what TJ described, to a olecranon osteotomy view. And this dye indicates that there's quite a significant variation in the amount that you can see anteriorly and posteriorly, but predominantly you get a much better view of the anterior trochlea. And also looking down, so sort of end on, the view is not too dissimilar, but you can see a lot more of the coronoid process that you can't see with your olecranon osteotomy. And when we look at the specific numbers, there's a significant difference. So we're approaching almost 100% in terms of distal humeral visualization, but also for view of the trochlea, we're approaching more than 95% visualization. And in a previous study with that Leah et al. Did, where they looked just at a lateral epicondyle osteotomy, but without the inversion that's been suggested in the rotation, they saw a lot less of the trochlea. And again, you can get about 70% view of your articular surface of the coronoid process. So not great, but much improved on the olecranon osteotomy. But there are some limitations. So again, your anteromedial coronoid tip is very difficult to view. And if you want to get to that, you really need to do a medial approach. It's possible with you taking off the lucal that you might get some instability, particularly with your terrible triad. And you need to ensure that you have a really good fixation. But I think, most people can do that quite robustly now. There's slight concern, particularly with younger people, about the blood supply, because the lateral blood supply comes anteriorly and posteriorly, as opposed to the more anterior base blood supply for the medial epicondyle. And of course, this is a cadaveric study. So without any soft tissues, the amount of distraction may not be representative. So I'm not sure that this necessarily alleviates all uncertainty, but I think a useful thing is that this is a really useful tool and something else to add to your armamentarium. So I guess the question is, will anybody be trying this? And that's it, really.
Great summary of the paper, great presentation. Thank you. Anyone have any questions or comments on the two papers? I've yet to, and I'm asking the audience as well, to read a paper that has shown a significant difference in outcome based on approach for the elbow. In fact, for most things, there is papers on the deltoid split versus an extended anterolateral for the proximal humerus. But so far, certainly in the elbow, I've not read of a study that's looked at outcome measures in terms of different approaches. I don't know if any of the panelists have read anything like that or seen anything like that. I'm just going to share again.
I think a slight difficulty is some of these complex injuries are not that common to do studies and have long-term outcomes for, but in terms of a surgeon stress, something like the Boyd or maybe this, obviously had to mention Boyd with Lee here, or this new elbow dislocation approach might give you a better view and therefore reduce the time taken to fix it, and hence actually your actual fixation might be better, but also your infection rate might be better. So I don't know, and I don't know if anybody on the panel has tried this technique that I've suggested and how they found it compared. I don't think Lee would move away from Boyd, but I don't know if anyone else has tried that. It's a sort, you get the view is not too dissimilar from Boyd. What do you think, Lee?
I'd do it through Boyd.
Yeah.
Yeah, I'd do it a slight different variation. So most of those papers with the lateral epicondyle osteotomy have come from a lateral view. They've come through a lateral approach. So they've done a lateral approach and extended it and taken off the lateral epicondyle. I'd do a Boyd and mobilize it on the lateral epicondyle. View me video on that. But the point for me is if I'm dealing with these injuries is actually to notice that the patient has already done their lateral epicondylotomy. And so if the patient has done their lateral epicondylotomy, sometimes all you have to do is mobilize and utilize that lateral epicondylotomy. Whether you come to a lateral approach like this paper and the previous papers you talk about it, or if you come with it from the back, all you have to do is mobilize that common extensor origin and the LUCL, and you can get the whole articular surface. It also is made easier if there is ligamentous instability in the elbow. The medial collateral ligament is also gone. I don't know what approach. I keep changing. I can't say I do the same thing all the time. But what I can certainly say in the elbow is we're still learning things, and we're not like hips. Hips, they showed for HO that indomethacin made a big difference. We need our own studies, our own information unique to the elbow, because the elbow is not a hip, it's not a knee. I think we're coming up to 20 minutes to go. I don't have anything more to say. I don't know if any of the panelists have anything to add, or if any questions have come through on the chat. There's a question popping up there now, Amal.
I can't see any questions yet. Can I ask something while people might be adding their questions on the... So, well, what is the favorite approach for you guys in Cambridge? Do you still resort to the olecranon osteotomy? And do you actually think that in the current day and age that there is a place for that approach, given that we also now know that because you have to fix the olecranon back and the problems that come off from that fixation, whether that should still be, that should still remain a favorite?
I think that's echoing exactly what James Allen has put in the chat. Should we still be using an olecranon osteotomy approach for any injury, or have other approaches replace this? Again, comes back to I have read a paper that looked at the outcome, but they were olecranon osteotomy, Van Gorder, and something else. And it showed no difference in outcome, no difference in complications. So Amal and James, I don't know. I know I've never done, or not, maybe 1 or 2 olecranon osteotomies in my whole career, because I don't know how to fix the olecranon. I'm hoping that suture fixation one will tell us how. That's a little poke. No, I've never done an olecranon osteotomy. So I used to do a Stanley approach with the triceps elevation, and since then moved to a paraolecranon approach. But you can, with a paraolecranon approach, a lateral paraolecranon approach, mobilize the elbow further on the lateral epicondyle to sublux the whole distal humerus. There is a move, I feel, in the elbow world to using more triceps on, but no one has proven that it's better. So James, I think you do what you do and what's good in your hands. Neil, you've raised your hand.
Yeah, so that same paper that you were referring to, comparing the posterior approaches, there was a difference in terms of the time taken. And I think the olecranon osteotomy was the fastest of those. Speaking to our fellows, TJ, the experience across the Atlantic is that, I think when we start out, it's probably easier to do an olecranon osteotomy. We all have access to the plates to fix it. But as we get more experienced and are being taught by our mentors like yourself, Graham and Salma, you're teaching us all how to do the Boyd approach and alternative posterior approaches. And then our confidence grows with that. And that's what I found in my, evolution of this. TJ the other day fixed one, replaced one, all through the Boyd approach, having never done it before. Is that correct, TJ?
Yeah, absolutely. Yeah, I never thought you could get that exposure being, like you said, from across the pond, be like an osteotomy in most places for those sorts of things, but you can see a lot with the paraolecranon.
James, I don't know if you could answer in the chat, what approach would you do for that articular fracture? I don't know how to interact with you. I don't know if we can let the panelists talk. There's only a few in, so. I see Neil is typing. Still experimenting. So I've been experimenting most of my life. Yes. Yeah, I can't say yet that you shouldn't do an olecranon osteotomy. And I think you have to do what you have to do to see what you have to see. But I think there are ways to progress to doing a triceps on and still having the exit option of an olecranon osteotomy. You always want to have an option for extendability. And so, yeah, I've never done an olecranon osteotomy, and I don't think I'm ever going to have to, now that I've increasingly learned to mobilize things on the lateral epicondyle and just tuck the lateral epicondyle in. But maybe in a year or two, I'll be seeing a little bit more of AVN, or maybe I'll be seeing a little bit more HO. It's still the beauty of the elbow and elbow trauma is it's still evolving. Salma.
Lee, for people who are starting out and want to try these new approaches, what would be your recommendations for maybe the kind of cases that you want to start? So would you suggest, and how did you learn, maybe start these new approaches on more simpler cases, or do you just save it for the complex ones and potentially get into a bit of trouble?
No, I think you need to do it on the simpler cases, and go to a cadaver course, an anatomy course, read about it, know that there are more approaches just than the olecranon osteotomy, the Kaplan and the EDC split, and then gradually build up your confidence. And if you start off, for example, with a lateral paraolecranon, you still have your olecranon osteotomy as an exit. It also depends how many elbows you're fixing. Increasingly, I think in the UK, we're becoming more and more shoulder and elbow, and there are some people who are just becoming elbow. But if you have to do all of the upper limb, or if you have to do the whole body, then clearly you need a more simpler approach, one that you're more comfortable with. It's a gradual progression, but there is a relatively simple progression from the olecranon osteotomy to a triceps on. Now, one of the cadaver approaches courses is the way forward, I would think. TJ, have you found it difficult to learn?
I found those more straightforward than I thought. Even the way we position is a bit different here too with the supine position. But after seeing one or two and then doing a couple, both tiers, Neil said, and then in the lab this week, and this is coming from a guy who hasn't done a lot of elbows in a long time, and it's relatively straightforward,
Okay, I think we're coming up to 10 minutes. I just wanted to show the different approaches. The one RCT on heterotopic ossification in the elbow, beautifully presented, Sandeep. Thank you, Salma. Thank you, TJ. Unless anyone has anything more, I think we'll stop there. Over to you, and Amal.
Yeah, I just quickly end with a question to Salma with the paper you presented. Is that okay?
Yeah.
In the paper, of course, they're adding an element of injury to say already injured elbow by taking off the on the lateral side. Have they, in the discussion, sorry, I haven't gone through the entire paper, have they described any clinical implications of what that might entail when doing it in a real patient? It's all very nice, of course, in the cadaveric setting, but in an injured elbow, how does that pan out?
So they didn't really, because it was a cadaveric study, they just alluded to the fact that obviously with a cadaveric study, your access is a little bit different, and concerns about repairing it afterwards and possible disruption of the vascular supply. But I think, as Lee alluded to it, thinking about what's damaged already so that you're minimizing further damage through your approach is useful. And I think what I learned from Lee and Graham that they said is actually the first thing you want to take, rather than necessarily having a favorite approach, we all have our comfort zones, might be to think exactly what do you need to see, what will you struggle to see, and then maybe work backwards and base your approach on that. So I think a clinical study looking at these, as Lee suggested, and maybe Lee should publish some of his data, would be a useful thing to see what the outcome is. I don't think anyone knows, and I don't know if anyone else on the panel has any experience of that.
Sure,
So
thanks.
my point would be, I'm not sure I'm going to do an lateral epicondyle osteotomy when it's intact, but often you'll find in those articular fractures, which is the time when you need to see the front of the elbow, the lateral epicondyle actually is already broken. All you have to do is mobilize it and take it a little further.
Yeah.
And what they were showing in that paper nicely is what you can see if you sublux the forearm off the elbow, you actually see more of the elbow than you can through the standard approaches.
Yeah, thanks. Any other comments from any of the panel members?
Actually, I confess, I don't know what inversion is.
So they basically just subluxed the forearm off. They pronate let me get this right. They've supinate PLRI'd the elbow off the distal humerus, and so they've just subluxed it off. I think that's what they're talking about there. So once you've released lateral ulnar collateral ligament in common extensor origin, you can then rotate the forearm off. They're basically just PLRIing it, I think.
Yeah, that's the picture.
But their approach, this one, if you go back to 2 or 3 pictures up, is they're still coming through a lateral approach. You can do that lateral epicondyle approach through a posterior approach through a void. That's, I think we'll leave it at that, just as things for people to think about.
Okay, great, thanks. I'm just going to put up the last closing slide if that's okay, unless anyone has any further comments to add. No. Sorry, play from the start. Yeah, this is the last slide. Just to say thank you to the panel and for all those who presented. So thanks very much. Joe will send out the certificates of attendance to those who have attended. The next Journal Club meeting is now, the date has changed. Previously, it was 20th of November. That's now changed to 18th, 7 to 8 p.m. That is going to be presented by the team in Glasgow, Paul Jenkins and his team. So please look out for the email from Bess to join into that meeting. And this is the QR code for Bestie. So those who are interested, please sign in. Thank you very much and good night.